he has been diagnosed during screening colonoscopy with relatively small, about 3.5 centimeter LST or LSL lesion with the dominant nodule, and the biopsy on the dominant nodule showed the high-grade dysplasia or intramucosal cancer. This is why we have scheduled for en bloc resection. New generation of a hybrid knife. This is hybrid knife flex. You can see it's a completely redesigned handle, which has much easier control, but also the beauty is the tip. You see, this is the final end of the catheter. The tip is very thin as compared with the previous one, but still we have injection capability. You see how beautiful it is. So you don't need to exchange device during the ESD, but now we have a very clear, very clean cut when we use these devices. I push pedal, I nicely elevate. We are using a simple saline solution plus indigo carmine, methylene blue, whatever is available, because you know using a blue dye is a great advantage in this situation because allow you first to demarcate better the border of the lesion, but secondly also to better recognize vessels and to distinguish between a mucosal plane and muscular plane. So now I'm injecting a little bit more and progressing. So if you can see to my movements are very simple movements. One of the tricks of ESD, if you can focus on me. So I'm using my belly to control the scope and I'm not touching the device. The device is fixed position, very stationary, and I'm moving gently the scope. And you see little movement on up and side movement like this and nothing else.
So in the rectum, I think it would now be no longer justified to do just piecemeal EMR because this has a major implication for patient if unnecessary surgery is done. In the colon, I think is still justified to do also piecemeal EMR. It depends on the local expertise, and as Alice said, it's also depending on the individual lesion. But in the rectum, an incomplete resection in an early cancer is very bad.
I was going to make 2 points. One is there is data on low risk morphology rectal lesions, if you can identify them, being safe to remove piecemeal EMR, but most of us don't have the ability to accurately differentiate low risk versus high risk rectal lesions. And then the second thing, I think, just want to make the teaching point that was just made and emphasize it. When you have these sort of flat lesions with a dominant nodule, as was mentioned, if you're going to choose piecemeal EMR, you need to make sure you remove that dominant nodule with a margin in a single piece.